Well, welcome to another edition of the GWU School of Medicine, Journal of Drugs and Dermatology, Dermatology Translational Science Lecture Series. First, I'd like to call attention to our sponsors for today. Without their support, it'd be hard to bring in world-class lecturers and leaders in the field of dermatology, so thank you for your support. So to the main event, I'd like to introduce Dr. Abrar Qureshi, who is professor and chair of the Department of Dermatology at the Warren Alpert School of Medicine of Brown University. A mentor to many, he's received numerous awards for this role, as well as for being an educator extraordinaire. He has supervised and trained many of the elite dermatologists in our field today, including Ruth Ann Vogels, as well as Anthony Marolo, both who have caught the autoimmune dermatology bug and have carried on that torch in their own derm room clinics throughout the country. He is a prolific publisher, author, with over 175 publications. Of note, one of his first publications back in the early 90s is one of nitric oxide in the skin, one I cite quite regularly in my own work, but since that time has really established himself as a leader in clinical dermatology, especially in psoriasis, and that's what we'll be talking about with us today. So without further ado, it's a great pleasure to introduce Dr. Qureshi.
Thank you, Dr. Friedman. Can you guys hear me? Okay. Very good. Thank you, Dr. Friedman. It's really a pleasure to be here. And I was thinking, combination of GW with Dr. Ehrlich here. Bring psoriasis. Sounds like I'm bringing, cold to Newcastle. But then Washington D.C. in this era of politics, it's hard to focus on academics. And last night on the flight here, I was on a JetBlue flight, and the entire plane, all the monitors we were actually flying during the debate. All the monitors everyone's watching the debate. No one's watching sports. ESPN was down, etc. So, all right. So, it's really a pleasure to be here. I thought I'd do something different and interesting for the next 45 minutes, and really tell you a story about psoriasis, at least the stuff that I've been involved with the last few years. These are my disclosures. And so what we'll do is really spend some time talking about my experience with psoriasis, starting when I was a resident and then growing through the last few years as an attending, focusing on a couple of areas. So clinical observations. I'll tell you different stories of how, when I was in clinic, I made a clinical observation with some smart residents around me, and then we took it and went somewhere with it. Maybe took it to the lab, maybe took it to the clinical research world, explored it a little further, and then it led to something new, and we're still exploring those areas. Talk a little bit about how we used some epidemiology, clinical research methods to do things, and how we're now using other molecular methods, including genome-wide association studies, et cetera. And then we'll try and tie that to the therapeutic developments that we're all lucky to be working in. So the era today we work in is so different in medical dermatology to the era that, let's say I trained in 15, 16 years ago, where we have access to all these amazing silver sort of bullet therapies, but they all have limitations and some advantages, and it's worth knowing how the disease pathophysiology fits with the treatments we have. And the theme for the entire next 40, 45 minutes is going to be that we're now learning again to work in the medicine environment. So with the multidisciplinary world of rheumatology in particular, but GI and cardiology, and Dr. Ehrlich shared with me today that maybe you guys will add to your derm room clinic and have derm room GI here soon, which is very exciting at GW. I'm sorry, cardiology? All right. We're working with GI very closely. So derm room cardiology. Right. Wow. All right, so this is a classic case. Patient walks into clinic, and this is a few years ago, maybe about 12, 13 years ago, and I saw this gentleman, he's in his 50s, and you look at him, he's got some plaque psoriasis. You can sort of see it on his lower extremities, down there. Use the arrow there. He's got his arms involved. You can see the umbilicus up close. You can see sort of the gluteal cleft right there. So he's got about, your classic 25% body surface area involved with what we call intertriginous or inverse psoriasis, right? So you guys are all familiar with seeing these cases in your psoriasis clinic here with Dr. Ehrlich. And he comes in, but what's interesting is there's a lot more, we know now about someone like him. So he's in his 50s. What else do you notice about him? He's quite overweight, right? I mean, we use the term obese, but obesity has a very specific definition. And the more we learn about obesity in the world of metabolic syndrome, the more fascinating it gets. So he is definitely overweight and obese. And in the past when I saw a patient like this, I'd say, okay, we'll give you some topicals for your intertriginous areas, maybe a different topical for your scalp, and I'll give you a different topical or 2 topicals for your plaques in your arms and legs, and send them out with 6 prescriptions, right? And each of them applied BID. Now, what do you think is going to happen when I do that? There's very little adherence. We don't use the word compliance anymore because compliance is derogatory. It implies lack of, right? So his adherence is pretty poor. Anything above 2 or 3 prescriptions, he's not compliant. He's an executive, works at I think at a law firm, dresses up, not going to apply a topical in the morning. So you're starting off basically not getting anywhere. But more importantly, he is overweight. And so now when we talk to a patient like this, we actually look at the patient, we talk to them about their body mass index, we weigh them, we even check their blood pressure, and then when we do a lab workup and we start thinking about systemic therapies, because his body surface area is quite significant, he's going to fail topical therapy in the long run, we start thinking about checking other labs and looking at him sort of from a systemic disease point of view. That's really what I'm getting at. So someone like him, we think about him, we sort of look at the literature, and we start thinking about how do you want to study people like this. So in terms of study design, from an epidemiology point of view, let's think about exposure, something that sort of provokes disease, and outcome. And so in this case, the question is, did the obesity come first? Did the psoriasis come next? What's really interesting is if you look at table 1 of all the phase 3 pivotal clinical trials for all the drugs that are approved now in the psoriasis space, they're approved for moderate to severe plaque psoriasis. That's first. And second, what's really fascinating about these studies is table 1. So I'm an epidemiologist. I always look at table 1 for a clinical trial manuscript. Table 1 will tell you that all the patients recruited to these studies that had moderate to severe plaque psoriasis, a lot of them were obese. That is, the body mass index was above 30 to 35. And so the question is, what came first? Was it the obesity, or did the obesity, sort of post-seed psoriasis? Is it because, the classic chicken and egg, they don't go out, they don't work out because they're embarrassed about their psoriasis, don't go to a gym, and hence they gain weight? What's going on? So we see more and more patients like this, and we start thinking, well, how do you examine this? So if you look at the literature, and this is in the last maybe decade and a half, 2 decades, people have made these observations over the years. We now even know that if you have a patient with severe, let's say, body mass index above 35, they're grossly, massively obese, above 350 pounds. They get bariatric surgery after running through all the, the prerequisites of going through the psychiatric evaluation, the diet evaluation, et cetera. Post-surgery, post-bariatric surgery, if they lose weight precipitously, the psoriasis gets better. So we know that might be some sort of link there as well. But the question is, what comes first? And so we were able to do some of this work, and I'm just going to show you some data slides, but I highlighted everything in red that I want you to pay attention to. So we had access to these large cohorts at the Harvard School of Public Health, and we were able to look and see, we had data on body mass index since age 18, reported over the years in these large studies. These are large studies of typically nurses and health professionals, a couple 100,000 people followed across the country over at least a couple of decades. And what we found was that as people's body mass index went up, their incident psoriasis, new onset psoriasis risk went up as well. And it's actually quite interesting. It's almost a dose response. So if you look across the top part of this table, this is basically body mass index. As the BMI goes up across the top, you see the effect estimates begin to become significant. So 40% increased risk above BMI 25 or greater, and then it goes up to about the same, and then actually more than doubles if the body mass index is above 35. And then if you look at age 18, similar kind of story. So if you look at weight above age 18, you'll see that the risk also climbs as the body mass index grows. So it's interesting, in these patients or these individuals, psoriasis occurred long after, but we had access to the data on body mass index, waist hip circumference long before. And so we were able to show, in well-designed prospective studies, that the weight increase came first, at least in these people. So what does that tell you? It makes start thinking about, well, if the obesity problem is preceding the psoriasis and is linked so closely, to body mass index, could this metabolic state be driving the inflammation? And so I think most people here in this audience, if I said, hey, obesity is an inflammatory state, most people would nod their heads, because we kind of, all hand wave and say that's true. We just don't know all about the mechanisms behind it. So again, thinking about from a translation point of view got us thinking. We looked at psoriatic arthritis. we found a similar kind of increase. If you look down this list, you see as the body mass index goes up, the risk of psoriatic arthritis goes up as well. So it sounds like both those disorders are linked. And now if you see a patient with psoriasis, and they are overweight, you should be thinking, well, right, so they were obese first. We also know that if they lose weight, maybe the psoriasis will get better. What is the link? Why is this happening? And so it got us thinking, more and more about this link. We knew that obesity now is a risk factor for psoriasis and psoriatic arthritis. At least in some of these people, most of these people, it precedes the onset of psoriasis. So if you go back to literature and start looking around, digging around, you'll see that there are a number of things happening in someone who's overweight. So bottom line, it gets really, really interesting. There are many types of adipose tissue. There's central obesity and peripheral obesity. There's obesity where you measure, do you guys remember from way back in med school where you could measure someone's nutritional status with the thickness of their arm skin, so it's subcutaneous fat? And then some people talk about central obesity, which is obesity around the omentum. Who remembers the omentum? So omental fat, visceral fat, that's central obesity. There's a whole series of articles and literature on central obesity and peripheral obesity. But what's really interesting is, if you look at someone who is of normal weight, right here, this cartoon here, the adipose tissue produces a hormone called leptin. People heard of leptin in general? Right? Okay. You've heard of the leptin diet? You've heard of the paleo diet? Very good. But there's actually a leptin diet too. So in someone who's normal weight, there's leptin production, but the leptin that's produced is normal amount. And what does leptin do? So when you eat, whoever had breakfast today, you should feel satiated by now because you had enough breakfast to cause leptin release from your adipose tissue that told your hypothalamus, part of the brain, that you shouldn't eat anymore. And so you get satiety and you stop eating. What happens in people who are obese or overweight is that the leptin that's produced, one is an excessive amount, but the reason it doesn't work is the brain is not sensing it. So there's leptin resistance. So the cartoon on the right side of your screen, what's happening is there's leptin resistance. So you keep driving leptin up, but the leptin does not really help satiety. So you keep eating. The adipose tissue grows, and you develop a hyperleptinemic state. The hormone that counters leptin is called adiponectin. It actually does the opposite. So you can see what else is happening here. If you have a hyperleptinemic state, leptin actually drives a bunch of these cytokines. Have you heard of these cytokines before? TNF-alpha, IL-6, right? So, and then there's a bunch of other hormones and cytokines. So there's actually a bunch of cytokines that are changing with this leptinemic state. And sort of mention a bunch more. So again, we're talking about adipocytes that are normal, and the adipocytes that are inflamed. I'm not going to go into details here because I don't want to catch you off guard, but the whole world of adipocytology is quite fascinating. There's a whole series of inflammatory cells, including special macrophages that are now implicated. But the bottom line, just for you to remember, is in a hyperleptinemic state, you're driving a Th1 response. Okay? And in some patients, a Th2 response, but Th1 is predominantly involved. And look at these cytokines involved. Interferon. Interferon drives psoriasis. It's a classic psoriasis cytokine. How do we know that? You guys may not have, probably too young to remember this, or haven't seen these patients, but a decade ago we were treating hepatitis C patients with interferon and ribavirin. Now we have these fancy new drugs, but when you gave someone interferon, the patient flared, psoriasis flared. And they had a very low chance of success on the hep C treatment, but the psoriasis flared. So these are the cytokines involved. So what's happening is, what I'm basically tying in for you is, you see a patient who's overweight. I've shown you clinical data that shows that these people were obese before they actually developed psoriasis. And we're pretty good, I didn't show you data, but basically the more obese they are, the worse their psoriasis. And what I'm also showing you is that these people are hyperleptinemic, or at least they have problems with the adiponectin levels.